We can get going.
You're good, Kelly.
All right, good. Welcome, everyone, to our CCCR speaker series. We are really happy today to have Dr. Josh Baker with us. So Josh is an associate professor of medicine and epidemiology. He's a rheumatologist. He's at the University of Pennsylvania, as well as the VA Medical Center there. He does work in really a lot of different areas. He's going to talk to us about RA and obesity today, but his work focuses on things like body composition, skeletal muscle health, metabolic health, disease progression, works mostly in rheumatoid arthritis, but does other things as well. So we are looking forward to hearing from you today. And I think we typically hold questions to the end, but we're glad to do whatever you would like.
Great. Yeah, I'm happy to have questions during. I'm having that moment of panic where I realize I have probably too many slides, but we'll work through that. Yeah. Please interrupt if people have questions that they want to bring up during the talk. That's great. I'm also happy to do them at the end. And yeah, thank you so much for the introduction, and thanks for the opportunity to present. I'm going to talk to you about a topic that I sort of started out my training, not really, when I started my research career, I didn't really know that this is what I was going to get excited about, but turns out that I did. And I think I've learned a lot from thinking not only about how obesity impacts our patients and thinking about that kind of important clinical association, but also thinking about how these things are done, how we do studies in this area, and some of the limitations of doing research in obesity. So I'm going to just go ahead and get started. Let's see if I can get this to work. Here we go. Some of my disclosures. So the talk basically starts with thinking about obesity and the risk of inflammatory arthritis, and also the association between obesity and severity of disease, and RA in particular. And then I'll talk a little bit about the epidemiology of obesity and mortality, which I think is really interesting and informative in how we think about obesity as a risk factor. And if you're interested in a story, I just listened to this recently. The F word is an on the media story from NPR, and it has Catherine Flegel on it. I'll talk to you about some of her work, but it sort of made me a little angry to listen to, because it sort of made light of, or made obesity sound like it wasn't as big a deal as I think it is in our for our patients and for our public health. So that was frustrating for me, and I'll kind of explain to you why I feel that way. And then I'll talk about body composition as another way of trying to get at things like obesity and other body composition changes, and adipokines, which has sort of been a more recent interest of mine in terms of trying to think about how we identify people with adverse metabolic health. The reason that obesity is so important, I think, for inflammatory arthritis is that it interacts with arthritis in many, many different ways. This is just my silly figure, just showing how that is. So, obesity can cause a lot of different changes in how people feel, and it affects their PROs. It can affect inflammation. It can affect comorbidity, lots of comorbidities that are related to obesity, of course. And then it can increase the risk of complications that are important to us. So I think it may be intuitive. It's a common comorbidity. Obesity is a common comorbidity, and it's very closely tied to a lot of the things that we care about. I'm going to start the talk by just talking a little bit about obesity and sort of the development and severity of RA. But before I talk about RA, I think I like to bring up psoriasis and psoriatic arthritis, because I think they're a little bit an easier example of how obesity might actually tie into the disease itself. So obesity has been known to be strongly associated with metabolic obesity, and with about a twofold increase in the risk of psoriasis for people that are obese. And also the higher quartile of waist circumference is also associated with about twofold higher risk. People who gain weight, it increases the risk of developing psoriasis. And the thought is that the adipose tissue sort of secretes inflammatory mediators, and those things float around in your blood and get into your skin, and it upregulates inflammatory cells in your skin and promotes the psoriasis. I don't know that we know exactly how adiposity leads to psoriasis, but the link there is very strong. It's not just true for psoriasis, it's also true for psoriatic arthritis. This is just showing you that about a twofold increased risk for psoriatic arthritis among people that are obese. And if you have psoriasis already, it still increases your risk by another 50% to develop psoriatic arthritis if you already have psoriasis. So both at an increased risk if you are obese. The rates of psoriasis go down if you've had bariatric surgery. This is a study by Maglio et al. And it's hard to do a randomized trial to give people bariatric surgery, but this was a very well done observational study where they took people who went to a bariatric surgery clinic. It's like thousands of patients who underwent bariatric surgery, and then they had controls that went to that clinic but decided not to get bariatric surgery. So of course there's still potential for confounding, but pretty much as well as you can do for an observational study. And they showed that the people that got bariatric surgery were much less likely to get psoriasis. And true for psoriatic arthritis, although there wasn't significant association, probably because of power. And there's other studies also showing that people's risk of psoriasis goes down after they've had surgery. And furthermore to that, not just reducing your risk of getting psoriatic arthritis or psoriasis, but actually involving yourself in a weight loss program and losing weight actually improves those things as well. So you can have an improvement in your psoriasis and an improvement in your symptoms of psoriatic arthritis if you join a weight loss program and lose weight. So all that put together, I think it creates a very nice narrative about psoriatic arthritis that people who that obesity really is linked to the disease itself. It makes it easy because psoriasis has something you can look at in the skin. It's not just a symptom that could be related to obesity for other reasons. So there's sort of this more clear link between obesity and the actual disease. So there's less clear link in RA, and I think I want to walk through a little bit of why that is so unclear, and talk to you a little bit about also the link with disease severity. So people have proposed a link between obesity and RA. So the link, you could think about this as a hypothesis here, but that you have obesity-related inflammation in the adipose tissue. You have macrophages that are activated by TNF due to the inflammation in the adipose tissue. That releases those cytokines cause netosis, which results in citrullinated peptides, which is one of the reasons that we think people get RA. And then you get this, if you have that happening on a regular basis, you get you get RA, you start to react to those citrullinated self-peptides, and you get RA. So that's the theory. So, you would expect that if obesity is one of the reasons that people get true RA, seropositive RA, that we would expect that obesity would be associated with ACPA. What we actually see, though, is that severe obesity is associated with development of RA, but it's primarily seronegative RA. So this is one study, pretty recent, showing that there was no association in this study between obesity or BMI and the development of seropositive RA, but there was a significant association with seronegative RA. And we did a review a couple years ago, and it's not a single study that shows this. There's several studies showing a similar association, that you don't really see this in the seropositive patients. You really see it for seronegative patients. We also see that in obese patients, they're actually less likely to be seropositive, more likely to be seronegative. So this is just data from an RA clinical trial looking at the rates of seropositivity across BMI category. You can see that the obese patients are actually much less likely to be seropositive. And so, it's very unclear that if obesity really is linked to the development of it's not clear that obesity is related to the development of seropositive RA. And if it's associated with the development of RA, it seems to be promoting seronegative disease. And I would bring up the idea that, perhaps there's a sort of psoriatic phenotype of RA that we're seeing here, but that true seronegative RA does not seem to be as strongly associated. Obesity is also associated with poor response to therapy in RA, suggesting that there's an association between RA and more severe disease. So this is a study showing that patients with RA who are obese were less likely to achieve low disease activity or remission compared to normal weight patients. And that's been seen in other studies where we see lower clinical response rates for obese patients with RA. And so it's been propose that obesity might promote a more severe disease phenotype, just as it does with psoriatic arthritis. This is a study that we did a few years ago looking at the development of disability in patients with RA. We did this in the Forward registry, but also in the VA registry. And you can see here that the rate of development of disability was much higher in obese patients, primarily severely obese patients. So, it suggests a more severe phenotype in the obese patients, but actually this was really independent of things like joint swelling and inflammatory markers. So things like that we normally think of as associated with inflammatory disease, this relationship was really independent of that. And it's hard to disentangle this from the relationship that we would normally see with obesity and disability in the general population. So I was interested in this and trying to figure out how to really get at that question. Is RA really more severe if you are obese? And I have had access to this clinical trial data where MRIs were done in all the patients in the trial. And we looked at the relationship between obesity and evidence of synovitis, bone edema, and bone erosion on the MRI. So this is just showing you by category here what the osteitis score or bone edema score in patients within those categories. You can see that the obese patients actually had significantly less synovitis and osteitis on the MRI at baseline in the trial. And this is despite really no difference in their clinical disease activity scores. And if you look at over the course of the trial, and this has been shown in other studies as well, obese patients were much less likely to show radiographic progression. So they're less likely to have new bone erosion or joint space narrowing over the course of the study, both on MRI and on X-ray. So really pointing away from the idea that the obesity is really promoting more active, inflammatory disease. And Mike George took these data and took it a step further to sort of look at whether obesity was associated with achievement of clinical remission over the course of the trial. And so we defined the achievement of remission in different ways. One was to use traditional clinical disease activity or DAS28 remission, and the other was to look at MRI remission. So the first thing to notice is that for clinical response, if you were obese, you were less likely to achieve remission in the trial. So BMI greater than 30 was associated with a significantly lower response rate. However, if you looked at the MRI remission scores, so over this is on the right side is the combined inflammation score, which combines synovitis and osteitis. And obese patients were not different in their likelihood of achieving a low inflammation score. They were actually more likely to have low osteitis by the end of the trial. So it certainly suggests that while we're seeing a lack of clinical disease remission, there doesn't appear to be any difference if you measure inflammation in the joints themselves. I'm not suggesting that MRI is the better way to assess disease activity necessarily. I'm just sort of suggesting that there's something different about assessing it more sort of objectively with an image than it is when we do our clinical response scores. So why might that be? Well, there's a lot of potential reasons why it's hard to really measure disease activity well in patients who are obese. One problem is that obesity is strongly associated with chronic pain. So a number of studies outside of RA have shown a link between obesity and both chronic pain and pain sensitization. There are many reasons why that might be. One of the most highly promoted concepts is the idea that obesity may promote inflammation, and then that inflammation may promote pain. I have not seen convincing evidence of that, but it is a very widespread hypothesis that you have upregulation of inflammatory cytokines, those upregulate other pain mediators, and that's why we have this diffuse pain in patients that are obese. But of course, there are many other potential reasons. We know about comorbid osteoarthritis in patients that are obese. We have sleep disturbance from sleep apnea, physical inactivity that's common, and even insulin resistance has been proposed to promote pain. So it's unclear why, but there's this very strong association between obesity and chronic pain. And I have to say, when I started thinking about this, I really blew off the idea that there was some direct relationship between obesity and pain, as opposed to that it was just through some other mechanism. But I do think that it's convincing that there's something more than just, they have more osteoarthritis and more spine disease. It seems to be like the rate of significant pain syndromes is much higher. So we looked at this in the Forward registry. This is looking at patients who are at baseline in the Forward registry and just looking at some of their patient-reported outcomes. And I just highlighted the fibromyalgia score here. So patients who were obese were much more likely to have a higher fibromyalgia score, in addition to a lot of other PROs, including pain. We also looked at whether being obese was associated with incident use of opioids. The reason this is of interest, I think, is first of all, opioids are overused, as we all know, and has become a major issue. But also, I wondered whether, we think of RA, well, most of the opioid use that we're going to be seeing in RA is likely to be due to the disease itself. And I didn't really believe that was likely to be the case. So I wanted to see how much of the rate of opioid use might be related to the obesity itself. So obesity was indeed strongly associated with incident opioid use, and it explained about 25% of new opioid use that occurred in the population. It's tough to do that kind of study and really estimate that kind of association or risk, but it's certainly a major risk factor for pain, and that I think that number of 25% really emphasizes that it has an important impact on the sort of public health of the problem. So obesity is associated with pain, but it's also associated with inflammation. So we did a study quite a few years ago looking at obesity and inflammation. So this is 3 different populations. We looked at 2 RA populations. One was the VA registry. One was a cohort that we put together of 3 different body composition cohorts that had measures of adiposity and lean mass. And then one was to pull data out from the NHANES study, which is a reference study from the general population. And we looked at whether the association between BMI and CRP, which is obviously commonly used to measure disease activity. And what we found is that, you might see, if you didn't see the control line on this figure, you might think that obese patients had worse RA because their CRP levels are higher. But in fact, that's actually an expected finding here. That's true for controls as well. And what I like to sort of think about with this, I'm not sure that you can really say this from this figure, but if you look at where the biggest discrepancy is between RA and controls, it's really actually in the people with lower BMI, not those with higher BMI. In fact, the people with severe obesity people with RA with severe obesity look more similar to obese controls. So what we figured out from the study also was that if you sort of accounted for this problem with sort of an inflated CRP due to the obesity, it suggested about 10% of the RA patients would have, we would reclassify their disease if we accounted for that. So I think it's just a common issue that we have in clinic, if you're aware of this problem, that trying to just determine whether the CRP is really elevated due to RA or whether it's just from the obesity that's present. And it's true for men, but it's observed more in women. But it's a problem for ESR as well. So there's not a way to sort of easily account for this currently. We just sort of have to be aware of it and try and consider it when you're sort of assessing disease activity. So we know that patients with obesity seem to not respond to therapy. This may be because of excess pain. It may be because of elevated CRP levels. We were interested in knowing whether this was something that this lack of response was really related to sort of a specific drug. A lot of the studies that looked at this were looking at sort of people starting a TNF drug. And one of the things that's come out of that is that there is this idea that maybe obesity impedes your response to certain medications, that there's a TNF sink. You have this obesity that's causing a lot of TNF in your visceral compartment, and that you give someone a TNF inhibitor, and all the TNF drug gets eaten up in the adipose tissue, and then you're not able to, it's not able to do its job. And then there were some studies suggesting that maybe that wasn't true for non-TNF inhibitors, but there were no head-to-head studies. So we looked at this in the Correvitas registry, looking at about 6,000 patients that started either TNF or a non-TNF therapy. And we did see that there were somewhat lower response rates with severe obesity, but we found no difference between the TNF and non-TNF therapy. So this is not a pathway-specific effect. We see lower response rates in patients that are obese, but it's not therapy specific. And I think for me, this is definitely, it's interesting because I think it suggests that there's not like a pathway specific biologic effect here. It's not that TNF drugs just don't work in patients that are obese. I think that's an important feature of this study. I think what it tells me also is that there may be something about obesity that is limiting response to therapy that has nothing to do with how well you're treating the RA. And I think that's something that has to be considered when we think about the sort of falsely elevated CRPs and excess pain that we see in patients with RA. So this is the way I think about obesity in relationship to the signs and symptoms that we see with RA. I think we clearly see that obesity is associated with some of the signs and symptoms, but it's not as clear that obesity is associated with joint inflammation itself. So as much as we'd like to take, I think the point of this section of the talk is simply to say, obesity may drive disease activity and sort of promote the disease in psoriasis and psoriatic arthritis, but it's not clear that it does in RA. It probably drives symptoms of RA, but it's not clear that it really promotes greater joint inflammation or increases the risk of developing the disease. And it's certainly not specific to one inflammatory pathway. So it's true even among patients that start TNFs or non-TNFs. So it's, I guess my point is to say, yes, we see lower response rates, but it's not clear that you should care. It's we should be thinking about more how to deal with symptoms that are related to obesity rather than trying to treat them differently related to, presuming that they have more aggressive inflammatory disease or that their type of inflammation is different. I don't think we have good evidence for that. Okay. So I'm realizing I don't know how much time I have here. I hope someone will keep me honest about time because there's no clock on my computer here.
Josh, you're at 10:24.
Okay, great. Thank you. So I like to talk about obesity in terms of thinking about metabolic risk. We have a simple measure of obesity, which is BMI, but it's highly flawed. And I think this figure is a nice way of thinking about that. It's from 2013 in Science. You can be overweight and obese and have good metabolic health. And you can be thin and have poor metabolic health. There's certainly a correlation between obesity and poor metabolic health, but they're not perfectly correlated. And I think that that's something that this figure sort of emphasizes, but is something to consider when we're trying to assess the risks of obesity. So the way I've thought about metabolic risk in RA is that we have a lot of risk factors for metabolic disturbance. We have things like inflammation. Patients with RA undergo weight cycling or weight fluctuations. There's physical inactivity, use of glucocorticoids, and aging. All of these things can result in some of the manifestations of metabolic health, including things like sarcopenia and frailty, metabolic obesity, hormonal changes, alterations in lipids, and insulin resistance, and those lead to some of the outcomes that we often observe in our patients with RA. But I think it's slightly more complicated than that. And this is sort of a little glimpse into how my brain works, but I think of obesity, inflammation, and metabolism as three parts of this triangle here, and they're all related to each other and can influence the other. So obesity is important, but it's also linked to inflammation, and inflammation can affect your weight. So, we have risk factors from all of these different areas, and all of them are closely linked to each other for a reason, and that's because they all help regulate your energy homeostasis. And so I think the point here is that we have in somebody with RA, there's a lot of stuff going on. And a lot of that has to do with trying to regulate energy. If you have an infection in your lung and your body wants to get rid of that infection, one of the main things that it does to do that is it has to regulate energy to be able to get immune cells to the right place, provide them, the energy that they need to fight off whatever infection it is. And that requires in itself sort of limiting the sort of energy in other areas or growth in other areas. And so I think the way I've been thinking about this is that if you can get a sense of what the energy homeostasis is in somebody with RA, it may help you identify people who are at risk for some of these long-term outcomes and complications. This is Catherine Fliegel's study from 2013, and it was highly controversial when it came out. And it was sort of where, if you've heard the term obesity paradox, that's sort of where that came from. It's a meta-analysis of studies looking at the risk of mortality in patients in different BMI categories. And the controversial part of her study was that she found that overweight was associated actually in a protective effect for mortality. That patients that were overweight were less likely to die. And this was mostly true for patients that were or individuals that were over 65 years. And the reason this was controversial is that we all grow up learning that being overweight is bad and that it's associated with comorbidities. And I think that this brought some light to the idea that perhaps we're over concerned about obesity. I don't think that this is true. So this is this NPR story that was on last week was talking to Catherine Flegel, and the whole story was about how we are over concerned about obesity, and the problem with that is that there's discrimination based on weight, and I totally agree that happens, but I think it's a very big mistake to think that overweight and obesity are not bad for health, because I think they are, and this study really underestimates the risks, and I'll talk to you a little bit about why. And the reason is that low and normal weight is associated with illness. So this is a study that we did in Forward Registry in patients with RA, taking the enrollment BMI, and we looked at the same kind of association. We looked at whether BMI was associated with mortality. You can see that overweight was not associated with a higher risk of death, and the risk of obesity was pretty modest. We see that underweight is associated with death as well. The problem is that patients that are in these lower BMI categories are there potentially for a reason. So people tend to lose weight when they get sick, and so our reference category is potentially flawed. So one of the ways that has been proposed to deal with this is to try and get a sense of what someone's lifetime weight was, or what their prior weight was. And we looked at age 30 BMI within the Forward Registry, and this is not actually measured 30-year-old BMI, but it's what the patient reported their BMI to be at age 30. And even with that sort of flawed estimate of prior life weight, you can see that the risk of obesity is much more significant. So the risk is now significant for the overweight category and significant for the obese category. Andrew Stokes has done some work in this area in NHANES, which also has prior life BMI, and also shown the same for the general population, really refuting some of the data from Catherine Flegel. So I think the important point here is that we have a flawed measure, and one of the reasons it's flawed is that it is often we're using a reference category that is not a truly sort of a fair reference category, because it includes people that are potentially sick and have lost weight over time. I think this is really significant because it really tells us that we really underestimate the risk of obesity in our population. So I would challenge you to think about some of the different studies you've done or that you've seen that include BMI as a covariable, and to recognize that BMI was really, the risks of obesity in that study were underappreciated because it was not, because of this epidemiologic bias. So I think it affects really all of the literature in the world that's ever included BMI as a covariate. And I think that when you think about it that way, it sort of becomes an important problem. We also know that it's not just how much weight has changed over time, but it's also important to know sort of someone's weight stability. This is a study that we did in Crevitas looking at weight fluctuation. And this we sort of defined this similar to a study by Bangalore et al. That looked at a cardiovascular study. And what you can see is that, so what we're really trying to do is distinguish two different weight phenotypes. So somebody who sort of has fluctuated a lot and had these big changes in their BMI over time versus someone whose changes are quite small, has had very stable weight. So you can do that by sort of measuring sequential variability in weight over time. And we did this in the Crevitas registry. You can see that those that have a lot of fluctuation in their weight and the higher quintiles of weight fluctuation have much higher risk of, or modestly higher risk, I should say, of cardiovascular disease. So there's something about weight variability that might help us identify people who have metabolic disturbances. And I like presenting this study because it's one of my medical students who's smarter than I am, who figured out how to do this better. She did a study in the health ABC cohort, which is sort of older adults who are highly functional. She looked at weight fluctuation of their first 3 years in that study and looked to see whether it predicted changes in function. The way she thought of this, she actually came up with a great idea, which was that you can't really just look at weight fluctuation because it doesn't, you can't really look at that without change. You have to sort of extract that, look at it independently from net weight change over the same period. So she did this, used basically the residual method to create a value that was independent of weight change. This is sort of a variability in weight that's independent of the net weight change over the same period. And when she did that, she showed that it was strongly associated with incident disability in this cohort. So not just with cardiovascular disease risk, but also fluctuations in weight may help predict people who are at risk of sort of frailty and disability over time among older adults, which sort of told me that weight fluctuation may be sort of a feature of frailty in the same way that is a feature of metabolic disturbance in other ways. So aging and illness alter relationships between obesity and mortality, which I think has a big effect on how we consider BMI in epidemiologic studies. Weight changes over the lifetime are informative, can be helpful. And I think, again, I challenge you to think about how this may affect how we think about obesity in clinical research in general. So this last part of the talk, I want to talk a little bit about some methods that I sort of had to struggle with over the last few years, thinking about how to better assess metabolic changes. Can we do a better job identifying people who sort of are healthy thin versus unhealthy thin? And I kind of think of the famous quote about pornography is, is it something that is really just too difficult to define, but you know it when you see it. We have patients who are thin, and sometimes we feel like we know when they're sick, but do we really accurately predict who's actually sick, who's thin because they're sick or thin because they're healthy? So one way to think about that is body composition. BMI is sort of a poor measure of body composition because it combines lean and fat mass. Lean and fat often have opposite effects on outcomes. So this is just a silly example to show you that you can have the same BMI and have wildly different or somewhat different body composition, and that has implications. For those of you who don't think about this every day, I like this example to think about how RA might lead to changes in body composition. And the first example here is somebody who has BMI of 25, they have pretty well controlled RA, and their weight and body composition doesn't change. But in somebody with severe RA, they can have a BMI of 25 and they can lose a lot of weight over time due to their severe RA. And that can result in, it not only results in weight loss, but you can have proportionally greater loss of lean mass because of how cachexia works. So you can be left with a similar BMI to the person that had controlled RA, but their body composition is very different. This leads to things like sarcopenia and sarcopenic obesity, which I largely think are exactly the same thing, except sarcopenic obesity people tend to have more fat, residual fat. I'm not sure that they are different in terms of pathophysiology, and if we had more time, we could talk about that in a little bit more detail. But you can see that these are we're left with two thin patients who have a BMI of 25, but the body composition tells you something about their history that's informative. You can do this pretty well with whole body DEXA. This is basically taking the attenuation properties of the muscle and fat. You can convert it to kilograms, adjust it for height, and make an index just like body mass index, and you can compare it to NHANES reference ranges and get z-scores. So you can do a lot with these measures to get a sense of where somebody fits in against the normal population. And this is just to show you that lean mass and fat mass are both very differently associated with physical function in RA. Those with greater fat mass have much greater disability, and those with greater lean mass tend to have better disability in a cross-sectional way. Of course, this study doesn't tell you about anything like how much of the disability is related to comorbidities. And it's very difficult when you have just a BMI and a patient in front of you to tell whether their disability, for their particular disability, is related to the obesity, the muscle loss itself, or is it totally unrelated to the two. One of the biggest issues that I had to deal with early on in thinking about this was this particular problem, which is that lean and fat are closely linked to each other. So if you didn't know that, it's something that a lot of people that actually do work in body composition don't understand. So when we assess muscle, it's confounded by fat and vice versa. So it's not a subtle correlation here. It's a very strong association. So what that means is that somebody who is overweight has more muscle than someone that is thin. And that doesn't necessarily mean that they have better function. So you really have to account for differences in fat mass when you consider muscle mass. And that's been poorly done to date. So one of the things we did to try and deal with that was to create a measure of lean mass that was independent of fat. You can see you can take the black dots here are the correlation between muscle and fat in the NHANES study. And we use the residual method, which basically takes what we would predict the person's fat to be and what their actual fat, or sorry, we predict their lean mass to be and their actual lean mass and take the difference. And you can use that residual to basically adjust for or take away the effect of fat. And so these gray dots represent the adjusted measure and how they're correlated with fat. So this is a measure of lean mass that's not associated with fat mass. So it allowed us to sort of ask, how does this person's muscle mass compare to what you'd expect given the person's age, rate, sex, race, and adiposity? You can see how this works. So when you look at muscle mass among women, if you just measure their muscle mass itself and you don't adjust it for fat, you can see that actually physical performance is actually better among people with low muscle mass among women without the adjustment. And so the reason that is that these people also have greater fat mass, and the fat mass is also bad for function. So when you use this relative sarcopenia definition, you end up seeing that what you'd expect shows up is that the low muscle mass, low muscle relative to adiposity is associated with worse function. We looked at this in gout too recently, which I'll point out. I got was listening to a lot last year at ACR thinking about low serum urate and its association with poor outcomes. And I thought, well, this is all just confounded by sarcopenia. But it's really hard to look at because obviously lean and fat are very correlated with each other. And so if we look at low lean mass, it's also going to be, those are the same people that have low fat mass. And since uric acid is very strongly associated with fat mass, it's a challenging confounder. So we were able to look at this looking at this is the urate level and the probability of having a low lean mass. And even when you adjust for fat using the fat adjusted measure, you can see that there's a greater risk of a greater probability of having a low lean mass at lower urate levels. The people with low urate levels also had much greater weight loss and were much more likely to be underweight, suggesting that really when we're seeing poor outcomes in people who have a low serum urate, a lot of it may be confounded by sarcopenia. And this definition of sarcopenic obesity, it was also very frustrating to me. We talk a lot about low lean, so sarcopenic obesity being people who have low lean, but also have a high fat mass. But traditional definitions of sarcopenic obesity actually identified people who have normal fat mass. So this is just showing you that for this traditional definition of low lean and high percent body fat, which is how traditionally this has been defined, those with sarcopenic obesity actually have lower than average. So their Z-score is less than 0, which means they have a lower than average fat mass, which means that they aren't actually overweight. They don't have excess adiposity at all. They have more than somebody who doesn't meet that definition and also has lean mass, but they're not overweight. So our definition, where we used a measure of had to have excess adiposity and a low relative lean mass, that actually identified people with significant adiposity. So these people actually have a high adiposity and a lower lean mass than you'd expect for their adiposity. And that's how we define them as sarcopenic obesity. And we looked at that relative to function. This is in the Health ABC study. You can see that the sarcopenic obesity patients had the worst risk of disability because they were both had low lean mass and had obesity. So their risk of incident disability was very high. And this is in contrast to what you look with the traditional definition, where sarcopenic obesity didn't really it was only marginally worse than having obesity itself. Sorry, it was only marginally worse than having low lean mass itself. We've defined body composition abnormalities in patients with RA. This is the risk of low lean mass overall, and then this is up here, the risk of sarcopenic obesity. And you can see the risk of sarcopenic obesity is about 3 times as high in those with RA. Low lean mass is more likely. And we also found that both of these, sarcopenic obesity and low lean mass, were associated with deteriorating function in those with RA. So it's not easy to do. Body composition can tell us something. It's very hard to do. Most of us don't have access to a whole body DEXA scanner, and it's unclear what to do with the results anyway, some of the time. I've sort of been interested in how we might think about or how we might do a better job screening for abnormal metabolic health and body composition using blood tests. And one of the things that we can measure is adipocytokines. The way I think about adipocytokines is that these things are when we're under, we're starving and we have increased energy expenditure, our body does a lot of things to our metabolism. One of the things it does is it upregulates adiponectin and downregulates leptin, which results in an increase in our appetite, increase in fat oxidation, and reduces unnecessary energy usage, like limits our growth. So one of the reasons that we get very high levels of adiponectin, for example, is just that we're starving, and so it's a molecule that's highly associated with being thin. So these things, as adipokines in general, are strongly associated with obesity, with visceral adiposity. They've been associated with inflammatory pathways, and they've been associated with biologic functions that have to do with energy utilization, including insulin sensitivity. So my thought was that these might be helpful as prognostic factors in RA. When we have adequate caloric intake and physical inactivity, the opposite happens, and we get upregulation of leptin, downregulation of adiponectin, and it may affect these energy in different ways. So we looked at adipokines in patients with RA and looked how it correlated with body composition. We found that all 3 of the adipokines we looked at, adiponectin, leptin, and FGF21, or fibroblast growth factor 21, all of them are associated with a higher risk, or lean mass was associated with higher adiponectin levels, leptin levels, and FGF21 levels. So after you adjust for BMI. So the thought here is that we can use adipokines to try and identify people that might be at risk for low lean mass. I don't think I have a figure here looking at the sort of ability of these measures to discriminate between those with low lean mass and normal lean mass. It did improve the diagnostic, improved the ROC curve a little bit and improved the area under the curve, but not to a point where it might be highly useful as a biomarker. So, but maybe in combination with some other methods, it might be a way to improve our ability to identify those that might benefit from screening. We also looked at adipokines and cytokines and mortality in patients with RA. And what you see is that those with really high adiponectin levels, and these are the people where we're worried about cachexia and sarcopenia, you can see that those are the people that have the highest levels of inflammatory cytokines in patients with RA. Leptin was not really associated in the same way. that people with higher leptin levels tended to have lower inflammatory cytokines. So we have this sort of interesting U-shaped curve here with very high levels of adiponectin being associated with inflammation. We see also that while adiponectin levels traditionally are thought to be associated with lower mortality in the general population, they actually are associated with a higher risk of death in patients with RA. And it's largely driven by cardiovascular death, shown here. We also have another paper that looked at another very smart student who looked at cardiovascular events, showing that a lot of the cardiovascular events were heart failure hospitalizations, in addition to mortality events. Really suggesting to me that this is like a cachexia thing, that these are people that are, it's identifying people with chronic illness and poor metabolic health with long term. He also looked at adipokines and how it predicted disease outcome, and showed that the patients with higher levels of adipokines were actually less likely to achieve low disease activity and remission. This was really independent of BMI. So people with high adiponectin levels, for example, had a lower rate of low disease activity and remission. Really, to me, suggesting, these people who have we're thinking that high adiponectin levels are associated with things like sarcopenia and cachexia, but these are people with a high risk phenotype. And I'll just mention also that there are several studies showing adiponectin being correlated with a higher risk of radiographic progression as well. So this fits in nicely with that story. This is something we're presenting at ACR this year. So don't tell anyone that I'm presenting here, but you can see that patients with higher levels of adipokines, people with osteoporosis and fracture at baseline in the VERA registry had higher adipokine levels, and elevated levels of both adiponectin and leptin were associated with a higher rate of osteoporotic fracture over time in the VERA cohort. And this is really independent of a lot of covariates, including BMI. Again, sort of suggesting that perhaps these measures can help identify people with adverse metabolic health that might be relevant to things like bone health. This is something that I've just been playing with recently that I thought I'd share, which is thinking about diabetes risk. And we know that adiponectin is thought to be very strongly associated with protective effect for diabetes. And I've been looking at this in RA, and we see that this is true in the sort of normal range, what we'd expect. So these are a couple of prior meta-analyses, and this is the range within which they studied adiponectin. And you can see that the sort of protective effect of adiponectin seems to be similar in that range, but there are a bunch of people in RA who have very high levels of adiponectin, and those people are not at lower risk. They're actually at the similar risk to those with the lowest levels. I thought that was really interesting. And then I don't think I have the figure here. I didn't add that in, but if you look at the cytokine levels in these people, they're very, very high. So they have high levels of all sorts of inflammatory cytokines and chemokines. And it really suggested to me that these are people who are the sort of more metabolically unhealthy, perhaps cachectic patients, and that might explain why they have a higher risk of diabetes going forward. And that this is just the reason I'm thinking that is just because we have shown that before, that in patients with RA, the inflammatory cytokines are highly associated with the risk of diabetes going forward. So even independent of things like BMI and disease activity, higher levels of circulating cytokines and chemokines are associated with a higher risk of incident diabetes. So it's to summarize some of that, I think, BMI is probably always going to be a sort of poor measure of metabolic health. It's not going to really fully assess, we're not going to really be able to tease out its impact on like the different sort of, is it a muscle problem? Is it a fat problem? When we're thinking about function and other outcomes, it's very difficult to use BMI to really give us a sense of what needs to get done for the patient. If we could have methods that would help us sort of independently evaluate the effects of muscle and fat, that might be helpful. But there's a lot of limitations in some of the definitions of the outcomes, such as sarcopenia and sarcopenic obesity, which really, I think, limits the clinical applicability. And I think we need to really define those things better for clinicians. And I'd like to say that in the future, maybe we can sort of better define what is a metabolically healthy versus unhealthy weight through different blood tests like adipokines. And I think that that's something that I hope is possible. I certainly feel like I have a lot of patients in my clinic who are thin and have had longstanding RA, and trying to determine really which kind of sort of bucket they fit in is sometimes difficult. So I think that with that, I'm going to stop. I hope I'm not too far over time, because I'd love to have questions, just some acknowledgements for a lot of the people across country that I've enjoyed working with over the years. And I'm going to just stop there and open it up for questions. Thanks so much for inviting me, and thanks for your attention.
Thank you, Josh. That was super. I don't see any in the chat, but I do see a hand. Lauren, would you like to go ahead and unmute and ask your question?
Sorry, that was just the applause emoji. I don't have a question.
Sorry, I just caught it out of the corner of my eye. Okay. Others have questions. Richard.
Hey, Josh, that was really nice talk. In the first part, where you're talking about the disconnect between clinical findings in RA with obesity and MRI and other measures, it's so hard to judge synovitis in obese people, when you're palpating joints. And I'm wondering if that's part of the disconnect in terms of, what you see when you have something more objective, such as an MRI.
I think it's a really good point. People have looked at that, trying to sort of look at it's very difficult when you don't have the gold standard, or like some gold standard measure of disease activity or joint inflammation. And I'm calling the MRI that, but it's probably flawed. I think Laurent Kaplan looked at this once in the VERA registry, I know, where he looked at whether BMI sort of changed the relationship between swollen joints and other disease activity measures, and showed that it did. So I think that there's some evidence that we do a worse job assessing joints in obese patients, but I think it's difficult to know whether that's a big component. But I agree. I mean, I think there's lots of ways that we get it wrong. So that's just add that to the list, I think.
Mm-hmm. Thanks.
Other questions?
I guess I have another question just related to obesity and the risk for various rheumatological conditions, because you showed psoriatic arthritis and psoriasis and rheumatoid arthritis. And we know, of course, osteoarthritis is huge in terms of the link with obesity. So, and those are three pretty different diseases when you look down at the biological mechanism. So clearly there must be other factors in addition to obesity, right? Genetics, other players. Is that also related to metabolism? So like if you look at genetics and metabolism, are some of those factors related? I know it's an area of active research, but I was curious if you looked into the genetic side of any of this.
So for psoriatic arthritis, I'm not aware that that's been done in a meaningful way. That I think that would be a great idea, to look at sort of the genetics of obesity and whether that's a risk factor for psoriasis itself, because I think it's sort of like an instrumental variable, essentially, where it's not confounded by all the other things that go along with obesity. I do think it is a metabolic thing. So if you look at the relationship, it tends to be with metabolic syndrome, with visceral adiposity, with waist circumference. So I don't think it's weight per se. I think it's more the metabolic consequences of the weight for psoriatic arthritis, at least. Obviously, with osteoarthritis, it's controversial. It's probably a little bit of both. And I think psoriatic arthritis is complicated also by the fact that it's similarly, there are a lot of symptoms of psoriatic arthritis that may be attributable to obesity, and sort of weeding through those things is very challenging. I was sort of focused on the RA part, but I think the challenge of psoriatic arthritis is that it's probably driven metabolically, and also all the other things that can cause symptoms are also relevant for psoriatic arthritis. So.
We have a few minutes. Any other questions? Josh, I don't know if you can see that, but Asya says phenomenal talk.
Thank
And as you
you.
know, she got some sleep last night, so she's a good judge.
She stayed up for it. I'm impressed.
I will ask one. They're screaming, so she can't log in and tell you that verbally. I'll ask something that's maybe going a little bit of a different direction, but just from health services researcher and exercise scientist kind of perspective. You talked more about lean mass at the end, and so just from a practical perspective, particularly thinking about patients with RA, and just from your clinical perspective as well. Where are we going wrong in terms of care? This is really, Louise might have some thoughts or questions about this too, but it seems pretty clear that there's lots of questions, but lean mass is good. Lean mass is important. So, what do you see clinically that's helpful, or what do you see in patients' trajectory that's not being done well? Just your thoughts either on research on that topic or clinical things.
Yeah, I think the truth about body composition is that it doesn't change very much. So even for exercise studies, it's not a great outcome because they can have a lot of improvement in function and not have their body composition change all that much over time. So I think from a patient perspective, I think it's a very reasonable argument to say we should be focused more on function because that's all that really matters in terms of exercise. I think I like body composition as sort of a prognostic biomarker, but I'm not sure it's a great longitudinal biomarker in that way. But the thing I have trouble with just assessing function, not to pontificate, but it doesn't really tell you why they have poor function. So like what you might change how you approach, the exercise intervention, depending on what the body composition abnormality is. Is it really a muscle weakness or is it overweight? So I think as we get more tools, that might be important. But from an exercise intervention standpoint, I think ultimately a lot of the way I approach things is that I won't measure this stuff. I just want to get people exercising in any way that's possible. And that since we don't have much resource to do that, it's I guess from a clinical standpoint, I think we're limited in what we can offer, if that makes sense. But I think we need better studies to show that there are specific interventions for specific people that we can, and then sort of advocate for those so that we can prescribe them. But certainly for RA, weight training things have been effective. It's just that you can't get them. You know what I mean? You can do some of this stuff. You can get people lifting weights and they will improve, but it's hard to give people the access to that as a physician. So I don't know if that answers your question, but
yeah, that's great. Louise, I say you unmuted? Were you
yeah, I had a follow-up question to that. Thanks, Josh. That was a wonderful talk, and I will likely be emailing you some follow-up questions. But one question I had at the end, you were talking about blood tests to screen potentially for sarcopenic obesity, and I was wondering what you were thinking about with, if you find a good screen, how will that be useful in what you do in the clinic?
Yeah, I think that's a great question because for a lot of people, currently we don't have a lot to offer, and I'm not sure it makes that much difference, but I think in the future it might. So for example, if you find out you screen somebody and it's very clear that their muscles actually look fine, it's really that it's the obesity that's the issue. Maybe you prescribe a weight loss treatment, whereas I think that's where it might be important. Ultimately, for now, I think I'm not sure exactly what it changes in terms of what you prescribe for the patient, but but I think prognostically there may be value as well, trying to decide what's somebody's risk going forward for certain things that might be a value. But in terms of how to intervene is very unclear. I think maybe one thing to maybe put out there, which is I wrote recently, and I guess can you do these things, identify people that have sort of adverse metabolic health, and then would you change how you approach their RA because of that? Would you treat them more aggressively because they have a more severe phenotype, even though they only have maybe that slight synovitis in that one digit? Maybe you treat them more aggressively. I don't know the answer to that, but that might be something that we think about as sort of a metabolic remission kind of approach if we think that it's related to sort of subclinical RA. But I think we're not there yet. So
Thank you.
All right. Well, thanks, Josh. We're at the top of the hour. Again, we really appreciate your time in preparing and coming to talk with us. That was fantastic. And yeah, we will hopefully be seeing you, some of us seeing you in a couple weeks in your home.
yes,
Right?
I'll be
in
here.
Your home city. All right.
Thank you all. Appreciate
Thanks,
your
everybody.
interest. Bye.
Bye-bye.